Welcome to today's two-part presentation where doctors Erika Hamilton and I will be reviewing novel endocrine agents. I'm Komal Jhaveri, and I'm a breast medical oncologist at Memorial Sloan-Kettering Cancer Center in New York. I serve as the section head for the Endocrine Therapy Research Program, and I'm also the clinical director for our early drug development service. So first, I will walk you through on the success story of targeting the estrogen receptor pathway and discuss the rationale for developing novel endocrine agents and where we see them fit in our currently existing treatment paradigm. Dr. Hamilton will then walk us through the clinical data for these various endocrine agents, including novel SERDs, novel serum estrogen receptor modulators or SERMs, SERCAs, PROTACs, and CERANs. The endocrine pathway or the estrogen receptor remains really a critical target for patients whose tumors have estrogen dependence. And the treatment landscape for the hormone receptor positive breast cancer patients has really steadily evolved over the past century. It was about 100 years ago when Sir George Beatson, for the very first time in 1896, described regression in chest wall nodules in a patient with metastatic breast cancer who had oophorectomy. And it took us about 100 years after that to get approval for the very first endocrine agent, tamoxifen, a serum estrogen receptor modulator that inhibits the transcription of ER target genes that drive cellular proliferation. Tamoxifen is a partial agonist of the estrogen receptor and works in an agonistic and antagonist fashion in various different tissues. For example, it antagonizes the effects of estrogen in breast tissue. It was about late 1990s, we then had approval for our next class of agents, which were the aromatase inhibitors. And these inhibit the conversion of androgen to estrogen in the body by inhibiting the enzyme aromatase. And they've been approved for our postmenopausal women, and we've been utilizing them both in late and early stage ER-positive breast cancer. And last but not the least, we have approval for a serum estrogen receptor degrader, fulvestrant, which was originally approved in the metastatic setting, in the second-line metastatic setting after patients had progressed on prior aromatase inhibitors or prior endocrine therapy, and that was in 2002. But it was not until 2010 when we learned the right dose that we use for fulvestrant in clinic, which is 500 milligram intramuscular injections in the buttocks every month. Now, it is really very important to note that these advances were really game-changing for our patients and have changed our standard of care. However, they did not have necessarily a huge, substantial efficacy improvement, meaning when we looked at trials that led to the approval of aromatase inhibitors compared to tamoxifen, the hazard ratio in those trials were 0.8, and the efficacy gain was incremental. However, the overall survival data were either immature or there was lack of significant overall survival benefit. And I think this is something we really want to keep in mind as we now see data emerge for these newer endocrine novel agents, such as oral SERDs. And we want to keep them in mind and provide context to this. Now, there are certainly challenges that we face with this currently approved agents such as tamoxifen, aromatase inhibitors, and fulvestrant. And these treatment challenges really arise from the limitations of these agents, which are not limited to its toxicity profile, but also to its pharmacological limitations. And what do I mean by that? We've seen emergence of ESR1 mutations. Now, these are mutations that emerge under the selective pressure of aromatase inhibitors, especially in the metastatic setting. And this is something that can lead to progression of the tumors. And in fact, 50% of the patients with hormone receptor positive breast cancer become resistant to these currently existing endocrine therapies, leading to therapeutic failure. However, many of these tumors do remain dependent on the ER signaling. Now, what about with tamoxifen? We said tamoxifen is a partial agonist, and therefore it causes weaker ER suppression. And that's why we think that there might be therapeutic failure to tamoxifen. And with fulvestrant, we know that it's an intramuscular injection, and so it lacks this oral bioavailability, which might be appealing. its efficacy is really dose dependent. And we saw that the 500 milligram dose was better than the 250 milligram dose, but we cannot go any higher. We have recent data now where patients who progress on a CDK4/6 inhibitor, which is our current standard of care in the first and second line metastatic setting, the efficacy with single agent fulvestrant is rather very modest in the range of less than 2 months. And so certainly we need to do better. And then we also have seen that those tumors that acquire the ESR1 mutations, not all of these ESR1 mutations respond to fulvestrant. For example, ESR1 Y537S does not necessarily respond very well to fulvestrant as well. So we certainly have all these challenges to overcome, which makes working on novel endocrine agents even more important. But last and not the least, when we think about these agents, aromatase inhibitors and tamoxifen are already approved in the adjuvant setting for early stage disease. And in the early stage disease, due to the toxicities of these agents, for example, we see hot flashes, we see arthralgias, myalgias. Patients really are not able to tolerate this, and the non-adherence rate can be really high. Certain studies have actually shown that about 50% of these patients are not able to complete the intended 5-year adjuvant endocrine therapy. And because of that early discontinuation, there is a 45% increased risk of a disease-free survival event in the early stage. And so we certainly need to do better. And because of that, the work that has been done over the past decade to develop optimal endocrine agents that can overcome the current existing issues, the current toxicity issues, the current adherence issues, the current endocrine resistance mechanism issues, and the pharmacological limitations, we have these exciting molecules, of which the oral SERDs are in furthest development. Now, Dr. Hamilton will walk us through the clinical data for each of these classes, including oral SERDs and others, and go through all the data that we have now seen in the metastatic setting. But what has also become very exciting is that these oral SERDs have also begun their journey for adjuvant therapy, and there are large phase 3 trials that are evaluating these agents for early stage disease with an attempt to improve our outcomes. A few examples of those trials include the lidERA trial, which is a trial that is evaluating giredestrant upfront compared to aromatase inhibitors or tamoxifen. And so these are for patients with moderate or high risk ER-positive disease. We also have trials such as AMETA-6, which is evaluating amcenestrant, another oral SERD by Sanofi. And in this trial, patients who had intolerance to aromatase inhibitors up to 30 months on their adjuvant journey. So anybody with 6 to 30 months of an aromatase inhibitors but intolerant to those would then be randomized to receiving amcenestrant versus tamoxifen. Interestingly, even the triple positive, or ER positive, HER2 positive patients can be enrolled on the AMETA-6 trial. And then we have 2 other trials, the Cambria-1 study with camizestrant and the EMBER-4 study with imlunestrant, which are evaluating the switch strategy, meaning patients would be either on AI or tamoxifen for 2 to 5 years for early stage adjuvant therapy. And those patients would then be eligible to and get randomized to receiving the oral SERD versus continuing the current endocrine therapy. And the goal ultimately here in the metastatic setting and in the early stage setting is to identify this newer novel endocrine agents that have the optimal therapeutic index and the optimal efficacy so that we can further improve outcomes for our patients. In the metastatic setting, we'll see that these agents might have a role either as a single agent that could be predominantly post CDK4/6 inhibitor. A lot of work needed here to understand who that right patient would be that would derive the most benefit with just single agent endocrine therapy, even though it's an optimal single agent endocrine therapy. And one such example or a surrogate of such an example is ESR1 mutant disease. So if you have an ESR1 mutation, perhaps you will respond to these agents better, is what we have seen. And Dr. Hamilton will walk us through that. We could see that these could be utilized with CDK4/6 inhibitors. But also, I think what we're now learning is that can we combine them with other approved agents? We know that alpelisib, a PI3K inhibitor, is approved for ER-positive breast cancer. Everolimus, an mTOR inhibitor, is approved for ER-positive breast cancer. And the question is, will these oral SERDs or other novel endocrine agents become the preferred partners with alpelisib or everolimus in the metastatic setting post CDK4/6 inhibition? So a lot of exciting work and a lot more to hear with respect to the data that Dr. Hamilton will walk us through. Thank you.
Hello, I'm Dr. Erika Hamilton, and I lead the Breast Cancer Research Program at Sarah Cannon Research Institute at Tennessee Oncology here in Nashville, Tennessee. Today, I'd like to discuss novel endocrine therapies with you. Certainly, we've had a lot of advances in metastatic hormone receptor positive breast cancer over really the past decade. We have new targeted agents, certainly PI3 kinase inhibitors, CDK4/6 inhibitors that have kind of taken this area by storm, as well as novel antibody drug conjugates for later line for patients as well now with emerging data from ASCO of 2022. But what we haven't had in the past 2 decades is novel endocrine agents. And we're at a uniquely poised spot in time right now where we've had some positive data presented, as well as some phase 1 trials of earlier agents across a variety of compounds that we know will be coming. So first, let's talk about the agents that exist. We have SERDs, CERCAs, CRANs, PROTACs, and SERMs available in clinical trials right now. And the most advanced of these really are the SERDs, so selective estrogen receptor degraders. So you can think of this as a pill version, and it works in a little bit similar way to the fulvestrant. But what we've seen in the post CDK4/6 landscape for our patients facing ER positive breast cancer is that fulvestrant and single agent endocrine therapy is just not performing the same as it used to. We have data from Emerald that we'll talk about, as well as Veronica that really looked at fulvestrant with or without the addition of a medication called venetoclax that was a negative trial. But the progression-free survival of fulvestrant alone in patients that have already seen CDK4/6 inhibitors in the first line is less than 2 months. And obviously, this is not good enough for our patients. So the novel oral SERDs we think are more active. They have the advantage of being active also in patients that have ESR1 mutations. And finally, they also are oral, which is obviously very convenient for our patients not to be having intramuscular administrations of fulvestrant. So our first trial that reported activity with SERDs was Emerald. The Emerald study was presented with elacestrant versus treatment of physician's choice endocrine therapy, had aromatase inhibitors as well as fulvestrant as options. And this was a positive trial. It improved progression-free survival from 1.9 months up to 2.8 and was statistically significant. Now, to be quite honest, I think we were all a little bit disappointed in the magnitude of benefit. And when we really dove in and looked at this trial, it looked like there was a good amount of patients that didn't derive benefit from either arm, from endocrine therapy in general. And what we're learning is that some patients post AI and CDK4/6 are really endocrine resistant at that point and probably are not appropriate for further endocrine therapy, but we haven't gotten quite sophisticated enough to be able to pick out who those patients may be. If we also look at the Emerald trial, if we select for those patients with ESR1 mutations, our magnitude of benefit is improved. It's larger. So it went from 1.9 months, again, with fulvestrant or the endocrine agents in the standard of care arm, up to 3.8 months with elacestrant. So certainly by picking out patients that have ESR1 mutations, we may be selecting patients that are more driven by estrogen, so driven by estrogen that they have this ESR1 mutation that has emerged, and a way to select patients that may have greater benefit. We have seen 2 press releases from 2 other oral SERDs that unfortunately we hear that their trials are negative, but it really remains to be determined why that may be, whether this was patient selection, difference in the drugs, the way the trial was designed, or power, the size of the trial, as we've not seen the full presentations for those as well yet. We also saw a unique trial called PATA-1 recently. And PATA-1 looked at patients that were receiving first-line aromatase inhibitors in combination with palbociclib, and they followed them serially for emergence of an ESR1 mutation. If an ESR1 mutation emerged for a patient while they were on first-line AI and CDK4/6 inhibitor, they were randomized either to get AI and CDK4/6 inhibitor or switch to be getting fulvestrant with palbociclib. So switch the endocrine backbone. And again, these were for patients that only had ESR1 mutations that were popping up, but not had any signs of actual clinical progression yet. And what we saw as part of that trial was there was benefit for switching to fulvestrant palbociclib. Those patients had a progression-free survival of over 11 months, where those that remained on aromatase inhibitors with palbociclib was only 5.7 months. Now, the big question that I have moving forward is those patients will still go on to get fulvestrant. And so what does the progression-free survival 2 look like? Or in other words, are we just using our therapies earlier, or are people doing better long-term with the so-called early switch strategy? And in fact, there's a trial enrolling right now called SERENA-6, which is looking at first-line monitoring for ESR1 mutations and randomizing patients either to stay on aromatase inhibitor in combination with CDK4/6 or switching to receive an oral SERD in combination with CDK4/6. So really looking at whether SERDs may have a place in early switch strategies. I think the most imminent place that SERDs we're probably going to see is in that second line space post AI and CDK4/6, but there's certainly trials like SERENA-6 for an early switch, or trials in the first line setting comparing SERD and CDK4/6 versus AI and CDK4/6, or even adjuvant trials. Fulvestrant actually beat aromatase inhibitors in the adjuvant setting, but by the time we figured out the exact dosing of fulvestrant and that we really needed to be giving 500 milligrams instead of 250 milligrams, patent life was out and the large registrational trial was never done, where I think we would probably all be using fulvestrant in the adjuvant setting instead of aromatase inhibitors. Briefly, I'd also like to just talk about some of what I called SERD cousins. So not SERDs, but also endocrine agents that work in a little bit different fashion. We have PROTAC, and this is a proteolysis targeting chimera. It's essentially a unique molecule that binds the estrogen receptor and then recruits E3 ligase. When it recruits the E3 ligase, it ubiquinates the estrogen receptor, which is essentially a fancy way intracellularly to flag the estrogen receptor for destruction. And so when this happens, the PROTAC essentially enables the cell to recognize the estrogen receptor, chew it up, and spit it out, is how I explain it to patients. We've seen data from ARV-471. This was a phase 1 trial, heavily pretreated patients who had a median of 4 priors. All had seen CDK4/6 inhibitor. Over 80% had seen SERD, whether that was fulvestrant or an oral SERD. And our clinical benefit rate here was 40%. They have expansions with ARV-471, and they also have expansions in combination with palbociclib. So I think that's a compound that we'll hear more about. Additionally, we've also seen recent data at ASCO for a SERM. So a SERM is a selective estrogen receptor modulator. We have a compound, an oldie but goodie, tamoxifen, which also fits in this category. But lasofoxifene was initially developed for vulvar vaginal atrophy. And they noted it had prevention and treatment of breast cancer characteristics. And so ELAINE-2 was a clinical trial that was a single arm trial looking at lasofoxifene in combination with abemaciclib for patients that had already seen CDK and AI, so essentially second line. 97% of patients had already seen a CDK4/6 inhibitor, and about half of patients had actually already been on chemotherapy. The progression-free survival here was 13 months, which I really think was very impressive to a lot of us. The overall response rate was 50%. So being a single arm trial, we can't fully kind of tease out what was the benefit of switching AI from one to abemaciclib or switching endocrine backbone to lasofoxifene, but certainly the combination of lasofoxifene with abemaciclib was quite exciting. So they have other trials underway as well. An additional endocrine therapy is the SERCA, or selective estrogen receptor covalent antagonist. It irreversibly binds without actually degrading the estrogen receptor. So it just causes an antagonistic conformational change. In the phase 1 trial, again, this was a heavily pretreated population, a median of about 3 priors. Almost 90% of patients had seen a CDK4/6 inhibitor. About 3/4 had seen fulvestrant, and a very similar clinical benefit rate here of about 40%. Progression-free survival was just shy of about 4 months. But again, if we select for patients that had clonal ESR1 mutations as a mechanism of resistance to previous endocrine therapies, our progression-free survival was lengthened to 7.3 months. So certainly we're going to be seeing more with that compound as well. And then finally, I'd like to talk about a CERAN, or a complete estrogen receptor antagonist. This turns off both AF1 and AF2 within the estrogen receptor. So both activation functions instead of just one, which is where most endocrine agents act. Similar story, the phase 1 included patients that were heavily pretreated. 50% of patients had seen at least 3 prior lines of therapy, almost universal CDK4/6 inhibitor, about 70% of patients having received prior fulvestrant, and the clinical benefit rate again here quite similar at 38%. So where do we go from here? I think in the coming years, we're probably going to have new endocrine agents for ER-positive breast cancer for the first time in decades, which is certainly very exciting. Being able to now combine our targeted agents with a new endocrine backbone. I think certainly we're all recognizing that fulvestrant and single agent endocrine therapy is not performing as well as we want it to for our patients who almost universally now are post AI and CDK4/6. Probably first to the stage is going to be our oral SERDs. And again, really, there's a lot of places these agents may end up. May end up second line after AI, CDK4/6, may end up in combination with CDK4/6 and replace aromatase inhibitors for metastatic disease. Certainly could be an early switch strategy. And we may even see end up in the adjuvant setting as well with trials ongoing. Thank you so much for joining.